So if we could have our speakers, if you're in the back, please move to the front 2 rows if you are one of the speakers for this session 3. So welcome back. This is our third and final session in our day-long symposium, Past, Present, and Future of HIV Research Informing Policy. This is our future session. Future New Directions. What research do we need to advance policy related to HIV and LGBT health? Some of you, I think we've had a little bit of changeover. I am Dr. Elizabeth Payne. I'm director of the LGBT Social Science and Public Policy Center, which is one of the conveners of this symposium today. Mark King is with us today as our facilitator, and he will introduce the panelists for our session number 3. So thank you all for being here, and we're going to go ahead and get started.
Hi, welcome back, everybody. So the future, what we're going to be focused on here are some of the strategies and the research being done, and then we're going to go to our discussion as we did before. I think that you would agree, with the feeling I'm getting is that those discussions afterwards seem to be really valuable. If we had only a few more minutes to do that and take more of your questions, that would be great. So I'm going to really hold the speakers tight on your speaking time, but don't worry, we're going to get and have a nice discussion as soon as you're done. Here are some speakers that you're about to hear from. First of all, Dr. Dimitri Daskalakis, and could you wave for everybody, Dimitri? There you are. He is with the New York Department of Health, but I love how he describes himself as a career-long physician activist. And that's actually true because he's got some very progressive views about HIV right now that I can't wait for us to include in our discussion. Joanne Morn is in your program as someone that was to be here. Unfortunately, she's ill, but she is nothing if not prepared because she has in her stead, we have Karen Hagos. Is that right? Yes. So I will give you her full biography. Karen is the director of the Office of Planning and Community Affairs with the New York State Department of Health's AIDS Institute. Her responsibilities include coordinating the implementation of the Ending the Epidemic Blueprint for the state here. She served as lead coordinator for New York State's Ending the Epidemic Task Force. That's quite a job. Good for you. And then we have Dr. Michael Stirratt. Michael, right there. And Michael is the Scientific Program Officer at the NIMH. Is that National Institute of Mental Health? Correct. Mental Health, okay. Division of AIDS Research. His focus is on adherence, and you'll be speaking a lot about that today. He was also one of the very first staff members to work at CHEST. Welcome home. And then for our discussants, we have Dr. Barbara Warren, who we heard from a little bit in our last session. There's Barbara, Director of LGBT Programs and Policies in the Office of Diversity and Inclusion at Mount Sinai, doing public health programs for quite some time, a public health policy person, which is going to be important to hear from. Dr. Lillian Barrios-Poli. Hi, did I get that right? Your name? Wow, these are challenging. Good, I did. And she is the chair of the New York City Health and Hospitals Board and senior advisor to the president of Hunter College. Good for you. And then finally, Jeff Parsons, who is, well, I meant that sincerely. I sound flip, don't I, sometimes? Okay, and that's Jeff Parsons. He's our birthday anniversary board boy. All things are about Jeff today, and we're glad that he's going to be back for the discussion portion of our program. So let's get started. Yes, I did. Oh, yeah, he was first. I'm all about him. Okay, without further ado, let's get on with it with Dimitri presenting on HIV and LGBTQ health research priorities in New York City. Dimitri?
Hi, I'm Dimitri, and I am here. Hello. Thank you so much. Do the slides, is this a next, or? Let's see, maybe down here. That's me. Great. So I had a very small task assigned to me, which is to talk about research priorities amongst from the LGBT and HIV perspective. And so, I mean, I'm really landing here as the Assistant Commissioner for the Bureau of HIV. So my focus is going to be a lot on that because it's what I think about the most, realizing that a lot of what I say actually requires us to look squarely at issues of health equity in New York City, which is a significant focus of our entire department, actually of this entire administration. So, I'm doing what I think are some of our highlights. And, you know, though I would love to say that we're researchers, we're not. We're implementers, so we do programs and evaluate programs, but as we launch programs in the city and in the state you're going to hear about soon, what happens is we create fabulous opportunities for future investigation. And so what I'm doing is giving you a little bit of a view, very brief, of some of the things I think are the most interesting that we're working on in New York City to really ask you what the future of research is, rather than have us sort of dictate it. I think that's a more interesting conversation. So the 4 things that I'm going to talk about a bit is HIV-related stigma, PrEP attitudes and uptake, the optimization of sexual health services in New York City, and then something that I think is really interesting that we don't talk about very much, looking at some sentinel events in New York. And one of the things that we don't talk about so much in New York City anymore is AIDS mortality. And so we're bringing it back to the table as something that we need to think about from the perspective of an area of investigation. So with HIV-related stigma, this is our new HIV-neutral continuum of care. This is version 1.0. We are feverishly working on a version 2.0 to inspire you more. But the idea is that historically, when we look at the continuum of care, it really starts here for people who have been diagnosed or who have HIV infection. Some percentage of them are aware of this infection. Footnote, in New York City, a serosurvey was just completed in the Bronx that compares to the serosurvey in 2010. 14% of people at that time were unaware of their infection. 5.9% are unaware now. So significant movement in that. But the bottom line is we see this side of the continuum focusing on people living with HIV, and they cascade down. Are they linked to care? Are they retained to care? Are they on antiretroviral therapy? Is their viral load suppressed? This is critical, and I'm going to talk about an area that needs to be researched further, but also it's important to realize, and I believe there's an NIH RFA that just came out about understanding the continuum of care on the negative side. Obviously, we'll be competing with you for that RFA as well, just saying. But definitely, just saying. But the idea of developing the PrEP side of the continuum and the negative side of the continuum is critical. And why do I say that? I'm not a researcher. I'm a stigma warrior. That's one of the reasons that I think that if we look at this story and look across the continuum for people who are positive and negative and realize the story is identical for those living with HIV and those at risk of exposure, we're going to change the story of stigma in New York City and the country. In fact, I'm really proud to say that New York City is the first jurisdiction to actually sign on to the statement that undetectable is in effect untransmittable. Yeah. So stop clapping and try to think of survey work to do to figure out what that means, because like we're going out there and now saying, and you're going to see it on the subway, HIV treatment is equal to prevention, negligible risk of HIV transmission. We are the first jurisdiction. After we did it, the National Association of State and Territorial AIDS Directors signed on too. So our little city changed what NASTAD did, which I think is pretty significant. So we're not the only ones, and there's the pictures of us being like, yay, we're doing it. But the bottom line is now you have to figure out how to measure it and what to see what people's attitudes are like as we make this giant switch, realizing that now 72% of people living with HIV in New York City are virally suppressed. And that when we look at the rate of decreasing new infections in New York City, it is not because of PrEP. It is stable condom use through the history of the epidemic. What it is treatment as prevention is changing the epidemic. It's the first step in ending the epidemic. And now the accelerator gets pushed faster with that negative side of the continuum. Speaking of that negative side of the continuum, PrEP uptake and attitude. So this is what it looks like in New York City as of 2014 of what prescriptions per 100,000 patients using our backdoor approach of looking at some EMRs. So what you see is that we have this epicenter of Chelsea and the Village where we have a lot of people who are getting PrEP prescriptions. And what we've done to respond to that is have built infrastructure everywhere, including PrEP including Chelsea and the Village, but the Bronx, Brooklyn, Queens, et cetera. So as we launch more borough-based strategies for PrEP launch, it's going to be important to have people who have ideas for how to measure that, attitudes, and also look at it from the perspective of equity and other populations. The good news is that we have seen significant increases in PrEP uptake in New York City. The blue bars mean awareness. This is using our sexual health survey, which is just a shadow of what CHESS can do. It's pretty good, but it's survey-based. And what we've done is we've seen increases in awareness up to 86.4% in spring 2015 and up to 16% of people actually using. So spoiler alert, my team's gonna get really mad at me, but our data is not just for research, it's to share. Over 90% awareness the last quarter we checked, and drum roll please, 29% of people that we surveyed are on PrEP at last assessment. Do not quote me, they'll kill me, but it's coming soon. You just have to know things are going in the right direction, but we need to know more. And a lot of the disparities in race that we saw at the beginning, at least in our surveys, looking like they're melting away. So more to come. So we're also going out to teach providers. So we're doing detailing. We have people who are going out there as drug reps that we've hired from New York City to teach about these interventions. It's a great area to investigate what providers think about PrEP and also what it would take to make them use it more. I heard Tony Urbina talking a bit about what it's like to go deeper into primary care. What about optimizing sexual health services in New York City? We're doing tons. We have our PEP Centers of Excellence. Tony Urbina here right now was carrying the cell phone for our funded program, the PEP Center of Excellence. He got a phone call for someone who needed PEP, and he's getting a prescription to them without a doctor's appointment to a pharmacy, happening in real time in front of you at this meeting. So he just whispered to me, "Thanks for funding me, kill me." So we're also actually pushing the feds around a little bit, no offense, by actually funding navigators to work with Ryan White Part A and to actually see HIV negative people to prove that Ryan White Part A structure is really good for people who are at risk for HIV exposure as well. So we're also launching a pretty significant PrEP network. We do all this, and then you guys should work on measuring it and apply for grants to figure out a way to better understand it. This is what our triad looks like. We're gonna be able to report some outcomes, but it's not the same as what a research community can do, latching on to what we're doing to sort of go deeper and further. Included in that is the fact that our STD clinics are launching pre-exposure prophylaxis immediate starts based on risk as well as biological markers, and also IART, or as we're calling it, Jumpstart, immediate antiretroviral therapy for people recently diagnosed with HIV. So it's a big machine that's starting to crank, and it cranks louder and faster starting January 2017. So by then, most of this will be up and running. We talked a little bit about treatment of HIV in the STD clinics, that's Jumpstart. We're also launching molecular epidemiology. So we're gonna be the first city in the country that is going to be taking on molecular epi. So we're gonna be offering real-time genotype testing to people newly diagnosed with HIV. We're gonna be taking those genotypes, feeding them into our system, identify growing clusters, and we're gonna work through our field services to help those people come to care sooner. So it's going to be helping us prioritize people who are both virally not suppressed and also potentially involved in a cluster of growing infections. This work, phylogenetics, this molecular epidemiology, can never point one person transmits to someone else, but rather just sort of identifies communities in which we have to do more work. It's actually a very exciting area. And so it starts in the STD clinic. If you're diagnosed with HIV, we are already doing resistance testing, and it's happening at our public health lab. So it's really an exciting time, a little bit of a switch in the story. It's gonna really help us better identify, and actually from the research perspective, learn better what transmission of HIV is like in New York City. One of my favorite slides, which I don't have here, is a cluster of 17 infections, all women, who've never met each other. There's a man in there. And so what happens by looking at the phylogenetics is we can identify not only these clusters, but then we go to the cluster and interview them better and deeper, and actually then can pursue like a deeper cluster and really change the story. With that said, it's pretty much doing what we do already, but with a little bit extra data. Then this is the one that I think is really different than most things that you've seen, our Sentinel event work. So this is our traditional HIV care continuum in New York City. So I told you 72% of people are virally suppressed. That's great. And just in terms of a little brag, UNAIDS says that by 2020 we should be 90, 90, 90. You guys have heard about this. We are currently 93, 91, 86, and next year we're going to be 90. So we're going to actually be precocious and be about 3 years in advance from the UNAIDS goal. Pretty amazing. We jumped 8 percentage points in viral load suppression in 1 year last year. Pretty good. But we think that mortality is really important to think about. And so what we did is we went into a time machine. And so we looked at several years of deaths in New York City, and we created a reverse continuum of care. So we looked to see where the breaks were in people's care access before their death. We deleted 3 months before their death because most people who are ill start to see the doctor more and they may get lab work. So we looked at the 12 months before the 3 months before they died. And what we found was that a couple of interesting things played out. So it's hard to see the text, but I'll just tell you that more people than we expected were actually linked to care. A pretty good number were actually retained in care, but then across the board with all deaths, we were seeing pretty low numbers of people who started antiretroviral therapy and even lower numbers who were virally suppressed. So then we looked deeper and said, what if we figure out how it looks from the perspective of HIV versus non-HIV related deaths? And a little bit of a surprise to us was that retention and linkage were not so much the problem, it was initiation of antiretroviral therapy and viral load suppression. And so it really has prompted a lot of quality work focused on not only reaching out to people who are not engaged in care, but those who are engaged in care and are not virally suppressed, because according to our data, they're at risk for death. And so this is an area of fabulous potential research and collaboration. So we're going to look at HIV deaths as sentinel events. And when we see one, we're going to, if we sort of get the right infrastructure up and running, which we intend to do, we will actually chase it to figure out where exactly the gaps in their care were so we can address it in the future. So I think this is a pretty interesting area for that as well. And with that said, I'm just going to say one more thing. My time is up. An area of a very important research that should also be looked at going back to the future is methamphetamine. So we're seeing increased methamphetamine-related deaths and increasing numbers of people who are using methamphetamine across New York City. It's been so significant that with the Ending the Epidemic monies that we've received from City Hall, we are launching the country's first municipally funded crystal methamphetamine program that focuses on harm reduction rather than abstinence. The only one similar to it is in Australia, and boy, would that be a really good one to evaluate. Anyway, thank you.
Thank you, Dimitri. You are hot smart. We're sex positive here. Finally, we have Karen Hagos, who is from the Department of the AIDS Institute. Her boss isn't here, who was going to present on defining the end of AIDS. So we don't know what Karen's going to talk about. Let's find out.
So I'm going to make this shorter because I'm shorter. I'm always willing to give up some of my time for Dimitri. So no, it's awesome. And it's always difficult to follow Dimitri. So I'll try to have the same amount of energy. I'm really happy to be here with you all today. I'm sorry I am not Joanne Moran, but I will do my best Joanne Moran interpretation. So I am the director of our Office of Planning and Community Affairs at the New York State Department of Health. It's a new title for me. I started with the AIDS Institute probably, I'd say 4 years ago, and I was really initially hired to focus on internal strategic planning for the AIDS Institute. 6 months later, the Ending the Epidemic announcement happened from the governor. My role quickly changed, which I'm really, really excited about and happy that it did. So we're going to test my eyesight here. All right. So I'm going to do a little bit, again, my day-to-day is really more on collaboration in terms of the epidemic in New York State, but I'm going to try to focus more on, I guess you wouldn't call it research, you'd more call it implementation science, if you will, in terms of what we've been doing. Something that's truly amazing, I think, within the AIDS Institute as well as in New York State as a whole is this ending the epidemic conversation has just spawned a lot of really great innovation. I think you heard a lot about that through Dimitri's presentation and others that you've heard today. So just so that we're kind of starting on the same page in terms of what ending the epidemic in New York State means, I'm sure you've all probably heard this, but in June of 2014, Governor Cuomo announced the Ending the Epidemic Initiative in New York State. There's a 3-point plan that follows that. Number 1, get individuals tested. 2, link those individuals to care so that they can achieve viral suppression. And 3, get individuals who need or want it pre-exposure prophylaxis or PrEP. And we also focus on PEP through that third bullet as well. So we're trying to reduce the number of new infections annually to 750 by the end of 2020. Something I'm going to focus a little bit on today in terms of some of our work is making sure that that's happening across all subpopulations. We've talked a lot about if we hit the 750 goal, which would bring us to subepidemic levels, if we're leaving subpopulations behind, we're not achieving success. And so that's a lot of what our work lately in the past year has been leading towards. So why did we think we could announce ending the epidemic in New York State? There's been a lot of key successes. I'm not going to go into every single one that you see on this slide, but some pretty major things. Decreases in HIV diagnosis due to injection drug use by 96% since the mid-1990s. I would also be remiss if I didn't mention that New York State just went a total of an 18-month period without one case of mother-to-child transmission in the state. That's pretty amazing. Thanks. I definitely didn't do that. It's a group effort. No, but really, when I'm talking about mother-to-child transmission, it's really a group team effort. If you listen to everything that went into that, it's state making policy. It's all stakeholders coming together and playing a key role from inception to the end of each case. So it's really important. And when you're looking at that work, it's actually a microcosm of the work we're doing in terms of ending the epidemic in New York State. All of these key stakeholders coming together and playing their vital role in terms of achieving this great success. I am definitely not an epi person, but this is an important slide. As I mentioned, the governor's announcement happened in June of 2014, so our comparison between 2014 and 2013 data is not yet realizing successes from our Ending the Epidemic initiative, but I just want to kind of provide and specifically point out to you that viral suppression number at the end is real, that 6,000 new individuals that we have virally suppressed in 2014. So we are seeing some advancements. But I did mention, our work in terms of subpopulations. It's not all success, right? It's not all success stories. Just a couple quick stats. 8 out of 10 new HIV diagnosis in 2014 were among people of color. 3,400 newly diagnosed cases, almost 60% were gay and bisexual men and transgender women, and another 14% had no risk response. So it's probably a significant proportion of those 14% are also likely MSM and transgender women as well. But it's not all, a negative story, right? So if you're looking at this viral suppression slide, you're seeing that I want to point you to the MSM transmission risk category. MSM actually have higher average viral suppression in New York State. So if we're getting individuals linked to care, that can really have a positive outcome in terms of their health. We kind of heard that from Dimitri earlier as well. I'm going to go into this in a second, but we do have several advisory groups that are developing, thank you, wow, 12 minutes goes fast. We have several advisory groups that are developing implementation strategies in support of the Ending the Epidemic Blueprint. I'm actually going to just flip right to that. So this is something, when the task force disbanded after the blueprint was developed, we developed this Ending the Epidemic subcommittee to our longstanding AIDS Advisory Council. And this group's been meeting for the past year and a half. It's about 20 individuals, again, kind of a microcosm of our task force. So you have stakeholders that range from activists to providers to researchers and the like. The group really came up with this idea of, let's go even deeper than the blueprint. How can we focus on key populations or key subject matter areas? And so we've formed these various advisory groups. Again, they're not going to be long-standing till the end of 2020. Each group is set up for a 6 to 8 month time span, and their charge is to develop implementation strategies in support of the Ending the Epidemic Blueprint. So I'm going to focus on two that have kind of finished their work. The Black MSM Advisory Group is actually presenting at the subcommittee meeting this Friday. It's open to the public. I'm going to put a little plug for that. I'm more than happy to give you the information for it if you want to email me at the end of this so you can kind of hear their presentation. But I'm going to show you, I'm going to list out some things that they've really focused on through these implementation strategies. So areas of focus from the transgender and gender nonconforming work group. They asked for specific implementation strategies around employment, education, healthcare, law enforcement, housing, community-based organizations, and immigration. And the Black MSM Advisory Group is really focusing on some similar areas, but I thought this is a really profound theme that has come up in both groups. HIV prevention and care, it shouldn't be profound, it should be every day, but HIV prevention and care fosters healthcare engagement and patient-provider collaborations before an HIV diagnosis. So I think that's what you're also hearing from Dimitri when we're talking about the HIV neutral cascade. So these are really great implementation strategies. Again, we've heard from people that there was worried that the blueprint would just be this kind of thing that sits on a shelf. Same with the implementation strategies. I can guarantee you these are items that we're using on a daily basis in the New York State and New York City Departments of Health in terms of, what are we going to do next in terms of our programming? How are we going to change our programming? Thank you. What policies are we going to try to impact? Another example of this is I think it was in 2015, state policy changed so that data sharing between healthcare providers and the New York State and local health departments, they could better share data. People might think, okay, what does that really matter? But when it comes down to it, it really impacts our programming and our ability to do certain things. So for example, we have a Medicaid match where we were able to actually match Medicaid and surveillance data and identify people in certain managed care plans who are out of care. We were able to then take that information and share it with the managed care providers and say, here's some individuals out of care. Let's also give you some funding to help try to link these people back into care. So that's just another example of how some of this great work can impact policy and eventually program. So focusing on LGBT health in the AIDS Institute is not a new thing. It's something that we've done for quite a while, but in 2015 we do have a new unit in terms of the LGBT health services unit, and we've also done some specific conferences and that sort of thing. So I just want to promote that. And then we are focusing more and more on kind of specific initiatives. We have a YMSM initiative. You can see all the various things that it's impacting there. But really, again, with some key focuses in terms of ensuring we're getting people access to the care and treatment that they need and deserve. There is an LGBT Health and Human Services Needs Assessment. I do want to make sure that I point this out to you. The needs assessment consisted of more than 20 community focus groups, as well as a quantitative survey of nearly 3,800 respondents statewide. Something we've also often heard and have come through in the implementation strategies is that we need improved data on transgender and gender nonconforming individuals. So we are really working to do this, but this needs assessment will also help with some of that and provide some very important and needed data. So this captures demographics, health status and access to care, barriers to care, survival needs, thank you, PrEP, and disparities across the life course. So I believe it's in the final stages of getting approved for release. So this is going to be very instrumental and might help to address or maybe highlight some needed areas for further research. There's a couple other things that I won't mention because I'm out of time. NYS HIV home testing giveaway really started in the city, but this is kind of an important project, which I believe city is going to be doing a presentation at Croy, so I won't give it away. But really, I think what I'm really trying to get at here is that we have some key programs and key policies, and we continue to try to be innovative in terms of what we're doing, but there's also this collaborative effort and this community voice that I can certainly attest to in terms of everything we've been doing with ending the epidemic, whether it's task force, whether it's a SurveyMonkey process, whether it's our advisory groups. So that's really important, and I think it's something that was important to Dan O'Connell and rings true for Joanne Moore as well as our new director. I'm going to end with this. This is I can't say this word, so mini grants for ending the epidemic in terms of research and evaluation projects. I'm going to let you know that Jim Tesserario is still in the back of the room, so if you have further questions on this, he'd probably be able to answer it for you. This is out on the New York State Contract Reporter. We're funding these mini grants, approximately 5 contracts at $30,000 each, and the due date's October 18th, so take a look at that if you're interested in potentially submitting something. Real quick, on the resources section here, we did just release our first Ending the Epidemic activity report on the Ending the Epidemic website. What this does is breaks down everything state as well as city is doing related to ending the epidemic, blueprint number by blueprint number. So if you've been really looking at, from an agency perspective or from a research perspective, honing in on certain recommendations, this will kind of show you what's actively happening in the state. And we'll continue to update this as we move forward. So thank you.
Next up is Dr. Michael Stirrett, and he's going to be discussing HIV research priorities and directions at the National Institute of Mental Health Division of AIDS Research. Thank you.
All right. Well, it's an incredible pleasure and honor to be here today, and I really want to congratulate CHEST on 20 years of success and making a real difference with their research. That's a great credit to you, Jeff, and everyone who's been associated with the center. I'm very proud to be one of the first employees at CHEST. Jeff gave me my start in the HIV field, and I'll always be thankful for that. I'm also very glad to be here at what's been a uniformly excellent forum all day long now. All the talks just really terrific, and it's great to be here to represent a federal perspective following city and state. So I'm going to talk to you as an NIH representative. And it's a legacy of the early days of the AIDS crisis, that almost every institute at NIH has a particular program which is focused on HIV. And each one of those individual institutes has its own, kind of mission interests. For us at the National Institute of Mental Health, we're focused on issues of prevention and treatment, and at the NIH, increasing work around a cure for HIV. But our particular strategies and foci for us at the NIMH Division of AIDS Research are really threefold. And one is to promote research that's behavioral and social science as it relates to HIV treatment and prevention. How can we strengthen some of these strategies that we have? Work on mental health, which probably is not such a surprise for the NIMH. And then we also have a component of our work which focuses on neuroscience. And today I'm really going to talk more about the first two rather than the third, given our interests here. I won't belabor this point because we've, seen this, several times here, but we really do live in like an extraordinary moment here in the HIV space, where recent years have seen all these amazing innovations, which are really very helpful tools for us. Rapid home HIV testing, so an HIV test is really no farther than your local Duane Reade. The benefits of early ART initiation through the START trial. We see that if people who are living with HIV start their medications as soon as possible, there's important clinical benefits for them. And then treatment as prevention, which we've also been talking about here. The HBTN 052 trial, gave definitive proof of that. But very interesting now to see this study, the partner cohort, thousands of HIV serodiscordant couples where the HIV positive partner has durable and sustained viral suppression. 0 HIV transmissions within those couples. So negligible risk indeed. And then finally, pre-exposure prophylaxis, which we've heard all about today. Finally we can say, a pill a day can keep HIV away, and that's really a remarkable moment. So it is true that we are definitely headed into this new era where we want to employ these biomedical tools, but at NIMH, what we would really want to underscore is that we really need to work on combination approaches. And I think that we've heard that kind of all throughout today, that it's important to have these biomedical tools, but we have to understand the behavioral and social and structural environments in which they're deployed if we really want to optimize their impact. So I won't belabor it, but we're all familiar with the HIV care continuum and the idea that there's important gaps, from HIV diagnosis to linkage to care, retention and care, and very interesting to hear from Dimitri this new data around ART initiation and viral suppression. something that hasn't always gotten quite as much attention just very recently relative to care engagement. But all of the elements of the cascade are critical. And these are really behaviors that we have to work on to help support if we want to really optimize the clinical benefits and the prevention benefits of treatment. There's also disparities in the care continuum. We see disparities by age as well as by race and ethnicity. And these continue to be challenges that we need to work on and are really indicative of larger socioeconomic challenges and racial prejudice and other important systemic and structural barriers that get in the way of being able to use these important tools. PrEP efficacy, we know that adherence is very important to that. This is a slide that charts, the results of clinical trials on PrEP, and what we see is that there was some variation in the adherence levels in these clinical trials testing PrEP. Those trials where there was higher adherence tended to show higher effectiveness in terms of preventing HIV acquisition. And then more recently, we've seen data, to suggest that, like with MSM, we probably would expect at least 4 doses per week to achieve a very, very high level of protection. And then there's, we're just getting, PrEP is so new, and it's important to explore all the data that's coming forward. But here and there, we do see some indications and some concerns about how PrEP use unfolds over time. It's good to hear the encouraging data from New York City here, but this is just one project. It was a demonstration project led by Al Liu, the US Demonstration Project. And what we have here, it's a somewhat complex graph, but you have Latino, African American, and white participants who are all taking PrEP. And over time, what we see is an increasing proportion of people who are not returning for their clinical visits and also declining adherence over time. And that's true across all of these racial and ethnic groups, but it's more pronounced among individuals of color. So, keeping our eye on disparities and how PrEP is used chronologically or longitudinally is something that we have to do. So overall, we do think that there's an important need for combination HIV prevention, for combining our biomedical strategies with behavioral, social, and structural approaches to strengthen their delivery and their impact. NIMH, I'll only go through this very quickly, but we have our key targets, a set of approaches, and then the populations where we want to deploy them. So our key targets include the care continuum and also adherence to PrEP as well as ART. And then we're going to do that through a variety of research, which include basic behavioral and social science, some translational work on intervention development. We need to look at social determinants, issues like stigma, for example, and then also implementation science. And so there's a range of strategies that in combination will be used to improve those targets. And we need to do that with MSM and other key populations. We think that these goals are actually in very close accordance with the larger set of priorities for HIV research at the NIH, which have been recently articulated by the NIH Office of AIDS Research. And what I'm going to do now is just highlight 5 areas of work that we're currently supporting at NIMH, and to give you a little flavor of some of the areas that we're working in. So the first is PrEP implementation science. And I'm actually very pleased to say this is the first time that this announcement has been made. But we did offer this announcement earlier this year and have been very fortunate to offer 8 awards underneath it. And what it is the CDC, our partners at CDC, have funded a very large set of demonstration projects on PrEP in 14 communities around the nation. New York City is one of them. And this research call asks for research supplements which would augment the evaluations of those public health demonstration projects by doing implementation science to study their processes and effectiveness and impact. And so we've now made 8 awards. They just happened in the last month. And they're at 8 sites throughout the nation. 2 of them are here in New York, actually. One is a team led by Lori Bauman, and another one is led by Sarit Golub, both working in partnership with the DOH. And they're doing a variety of work around the PrEP landscape, linkage, navigation, prescribing, and adherence. So implementation science, what can we learn from the actual real public health implementation of PrEP that can help give lessons learned to strengthen its delivery? In addition, we're also calling for research on improving the PrEP cascade. And this is also very timely to be here because we just published this on Friday, and Dimitri made mention of it. We're happy to talk to Dimitri and Jeff and anyone about your work and your interest in this. But our concern is that there is this potential for a PrEP cascade, and we've talked about that a little bit here today, that among the universe of individuals who could be on PrEP and benefit from it, not everyone has heard of it, and not everyone has access to care and linked to care. engaged in PrEP care and adherent to it. And so ultimately, the impact of it is reduced at each one of those stages. What kinds of interventions can we develop to strengthen the PrEP cascade and ensure that we have maximum impact from PrEP? So this is a research announcement calling for research applications. They're due in January. And I'm very pleased to say that NIMH led this and now has a partnership with NIAID, NIDA, and NINR, and these groups are collectively going to contribute $7 million in the coming fiscal year to support this research. So happy to talk with you about your ideas. And then technology-delivered interventions is another area of focus for us. The fact is that PrEP is an incredibly important tool, but as has been noted today, it is not for everyone. You know, it's probably about 1 in 4, as according to the CDC estimates among MSM, yes. So we need to empower people by giving them opportunities to explore the range of prevention options that are available to them. And sometimes that could be done by meeting them where they're at. You know, people are online and they're looking on mobile apps, you know, to find sex partners and to connect with one another. And so if we can deliver, you know, interventions that introduce prevention options to people through these technological strategies, you know, that's a great way of doing that. And this is just one project that we support, which is to Jose Bauermeister. I probably could have selected a chest-related example for each one of these, but I thought I'd go ahead and introduce some other ones, knowing all the other good work that's been highlighted today. Mental health is a focus for us, and this is a project that's led by John Panchenkas, recognizing that, you know, there is a social context, and even in the incredible day that we live, you know, today, there still is terrible prejudice and homophobia, heterosexism in the world, and that does have an impact. It's a minority stress that can affect people's mental health. And so John has developed a 10-session cognitive behavioral therapy, which is LGBT affirmative. And the idea is to interrupt the deleterious impacts of that kind of minority stress and discrimination on the mental health, and then ultimately the engagement in HIV preventive options, you know, for MSM. And so, you know, these kinds of strategies to work on people's mental health to improve HIV outcomes is another thing that we're supporting. And then finally, of course, we've talked a lot about the care continuum, and we continue to support all sorts of work promoting care engagement. This is a very large project that NIMH supports in conjunction with our partners at NIAID, and it's being done in the large research network, the HIV Prevention Trials Network, or the HPTN, and it's known as HPTN 078. And in this trial, which is led by Chris Byrer and Bob Remian, who's here today, what they're doing is really testing two things. And one is whether a novel strategy for reaching individuals, MSM, who are not currently in care and who are who lack viral suppression. And that they're doing that through deep chain respondent-driven sampling. And this is a strategy where you incentivize individuals to refer people to the study. And the hope is that after you get through 7 or 8 rounds of that, you're reaching a rather hidden and marginalized population, the very people who are probably most disconnected from care. And so those individuals who lack viral suppression are brought in and then are randomized, and this trial will test the impact of a multi-component care intervention, which is driven by a model of social work and care management, and also includes things like mHealth social supports to try to improve their engagement in care and their viral suppression. So a range of work, you know, from PrEP implementation science all the way out to strengthening the HIV care continuum, you know, the many kinds of behavioral and social and structural factors that are in between. And for us at NIMH, you know, we really think that it's a matter of bringing together that big picture, being able to work in all these areas in order to, you know, make real impact. And I think beyond, you know, the kinds of different work that we might do that's biomedical, behavioral, or social, it's also a matter of bringing together the teams and the partners. And I think that that's something that we see here today in terms of partnerships between CHEST and local community groups and the DOH and our state as well as federal partners. So, you know, it takes a village, and it's great to see that here today. Thank you so much.
Thank you very much. We actually have 3 discussants that are going to follow. They'll be speaking for 5 minutes on their observations about what it is we've just heard, or their general observations, and we're going to have that group discussion. Our first discussant is Dr. Barbara Warren of the Mount Sinai Health System.
You know, it's interesting. I said to Kenyon, who I've known for a long time as he was leaving, I said he and I have like a Vulcan mind meld, because some of the notes that I made prior to even coming here and hearing all the wonderful presentations today were very similar to some of the things that he said. So I kind of made a list, and I'm just going to go through it really as fast as I can. A couple of things came up for me, and one of the first things that came up for me was I was thinking about a lot of the research that's been done around teen pregnancy prevention, and it sort of correlates to what he was talking about in terms of looking at maybe the analog of the pill and where, and it's not exactly the same, but where there are similarities. And I went on, I've been working for a long time in an organization called CUE, Consumers United for Evidence-Based Healthcare, with the advisory committee to the U.S. Cochrane Center. So I've been very involved with the Cochrane collaboration, the international gold standard, right, for evidence-based reviews and for systematic reviews. And so I went on to the Cochrane Library, something I learned to use a number of years ago, and I looked at the systematic reviews, and they're actually, without going into any details about it because we don't have time, there are actually some very, very strong evidence for what works in something that's been eluding people for a really long time and still does in certain ways is teenage pregnancy. And there's some interventions there, and there's some correlational issues. So I think we need to think a little bit out of the box when we look at like where we're looking to inform anything that's related to sex and sexual behavior, where we're looking at health and health-related issues. I'm really glad to see what Michael presented about minority stress. We've been teaching minority stress at the Icahn School of Medicine. I also want to, and the sort of biopsychosocial structural model is really important because there are physiological effects of minority stress. Oftentimes we talk about in terms of the mental health effects, but there are lifelong physiological effects. It increases inflammation, and there's research now that looks at cortisol levels and brain behavior and neurological development. And we're not looking at the impact of minority stress way back to coming out and before that, and the intersection with the minority stress around, particularly now what's going on in this country, that's sort of in everybody's sort of vision, and that is the issue of race and racism. And I think that looking at those intersections are really, really important in terms of the impact, particularly listening to the presentations today, the impact on even sustaining people in care. I would hypothesize that there's a relationship between minority stress at the intersection of race and and socially derived minority stress from race, not internalized racism and not internalized homophobia, something I actually don't believe in anymore. After all the years I've worked in the LGBT movement, the Pulse nightclub happened, and a whole bunch of people that I know personally, all of a sudden, like, who are very well adjusted, locked themselves in their apartments and couldn't get out of bed for 3 days. So there's a physiological effect of that as well as a psychological effect. So I think we need research there. I also, my favorite thing these days is medical education. That includes nursing. Jeff and I know how frustrated we were. We tried for how many years to get a grant to look at the impact of all the education that we've been talking about doing today. We've been talking about doing a lot of education with providers and patient-centered care and PrEP and PEP, and how do we teach the next generation to really do patient-centered care with all the folks that come into care. We have no idea what the impact of that education is on patient outcomes. And that dot that's connected there is we need a mandate to collect sexual orientation, gender identity, gender expression data in electronic health records, in any kind of implementation that we do. And we need mandated training. Some of you know that the city of Washington, D.C., well, it's actually not a city, but it's whatever it's called. Washington, D.C. now just mandated for licensure, initial licensure and certification and renewal, that all healthcare providers across the spectrum, both primary care, behavioral health, et cetera, have to take so many hours of LGBT education every year. They need to get initially licensed, and now they needed to get renewed. We've been talking about that for years. Oh, you can't mandate, what education, yes, you can, and Washington just did it, and now we need to look at the outcomes. We need to look at what works in that education and what the outcomes are. And in order to measure those outcomes, we have to collect sexual orientation and gender identity in electronic health records. So there's a lot of dots that connect here in terms of what we need to look at in addition to the focus on HIV-specific stuff that's all connected. So that's all I have to say. Thank you.
Next up, Dr. Lillian Barrios-Pauly, chair of the New York City Health and Hospitals Board. Hello. Hi.
Hi, I'll be very brief. Essentially, I have spent the larger part of my life in public policy and in mostly social services, but also healthcare. And I think we're seeing, thank God, a big intersection about both things really coming together and looking at the more holistic view of how do you really treat, HIV, not only looking at the physiological things, but also at all of the behavior and all of the mental health components that it has. So I think it's a great day. I think also we're seeing in the Department of Health in the city of New York a whole new day in terms of how do you look at HIV, and I think we're particularly grateful and thankful to have Dimitri there, which is a big tribute to what do you accomplish when you bring somebody who's been an advocate all their life and put him in charge of the place. And you do get progress. So that's a very important thing. And I think the most challenging thing is how do you bring continuity to it? Because we all move on in our lives, and then how do you make sure that whatever advances we've accomplished continue and become a way of life and a way of doing business for the Department of Health, but for all the other departments. I spent a long time at the health and hospitals, and the big challenging thing there is it is the front line of defense for the poorest people in the city of New York, for those who have not insurance, for those who are undocumented. And many times, there is a profound ignorance of what they're entitled to. There's a profound ignorance of what's available. And we don't take enough care to make it available and make sure that they understand what's available to them. So, it's a real challenge. We've made some progress, uneven. We have 11 hospitals, and they all function very autonomously, unfortunately. And some are great centers of excellence, and some have a way to go. But it is a very important place to do research, and it's a very important place to make sure that policies that make sense are applied, because that is where a lot of the center of the epidemic happens. Poor people, people of color, people who are not insured. So I think the future is bright, but I think we can never declare victory and feel that we've gotten there. 2020 will be the end of the epidemic, but it's the beginning of making sure that it doesn't come back. So thank you.
Great. So our final panel discussion of the day on this, again, I'm going to try to be conscious of raised hands from the audience. I'm going to get them warmed up with a couple of things. Dimitri, I was impressed that right away you mentioned undetectable equals uninfectious. And I know that this is data that we've known for a couple of years, at least the preliminary partner study data, but it's something that's still being kind of absorbed by the community, especially now with this new campaign, the Prevention Access campaign, to get the word out about that. A lot of people still kind of skeptical about that, have a lot of fears about that. But and even in an earlier presentation, somebody mentioned, the importance of using PrEP, even if the PAS partner was undetectable, because you never know. Whereas this language kind of says, no, you do know. You do know. How is this, I see this, speaking of the future, as a discussion we're really going to be ramping up in the next year or two.
I think that one of the studies that we haven't talked about so much yet is not really a study, but a demonstration project, was the Partners PrEP demonstration project, which is a follow-up to Partners PrEP. So for those of you who may not know what that is, it's a study that was not randomized. Couples, one had HIV, one was HIV negative, were recruited into the study, and they were given the option that the negative partner can start PrEP and the positive partner can start antiretroviral therapy. And so some proportion of them started PrEP and antiretroviral therapy, and the strategy was that you were on PrEP for 6 months while the positive partner was virally suppressed. And after 6 months of viral suppression, PrEP was stopped. And what they found in the study was that they expected 86 8.6 per 100 person years of HIV infection, given sort of standard ideas. And what they in fact found instead was that they only had 4 seroconversions. The stereo instructions of the study, however, are critical because the 4 seroconversions were in people who were not on PrEP, nor was the partner on antiretroviral therapy. So technically, the PrEP to viral suppression strategy resulted in 0 transmissions of HIV infection. So I think that we're going to have to nuance what we say and what we do and what the role of PrEP is. So right now in clinical practice, I wish Tony were still here because he would vouch for this as well. We often tell people that it's a belt and suspenders. So if your partner is virally suppressed and you have some anxiety and some concern or unsure about the viral suppression, then PrEP seems like a great option. But for people with consistent viral suppression, I think that the future is going to be that PrEP will be a bridge to getting a virally suppressed stable partnership. And if there is a stable partnership in that way, then PrEP may not be necessary as a long-term intervention, which may also have some cost implications.
I heard throughout the day from 3 different presentations the concept of minority stress. And I admit that I've never heard that term before. I take it not to mean limited to racial minorities, but also sexual, gender minorities, et cetera. I think to myself, why did I drink? Why do I smoke? Why do I bite my nails? Well, I grew up a gay boy in Louisiana. For God's sake, I was a nervous wreck. You know, is that minority stress? And if so, can you quantify it? Have you as researchers been able to quantify the effect of minority stress? And how are you dealing with this in your research and in programs and in policy going forward?
Oh, now it's green. So, yeah, that is minority stress. It's not just about race. In fact, the term minority stress was coined by Dr. Elon Meyer. Some of you remember when he was at Columbia. He did the initial research around looking at the impact. Well, he sort of went backwards, almost like a sentinel event, looking at folks with major mental health problems who are gay and lesbian identified, and then looking at sort of tracing back to what their histories were, and a lot of it was related to the impact of life experiences, particularly life experiences of heterosexism and homophobia and trauma, and socially derived trauma. We always look at other kinds of trauma. That research now is extended beyond LGBT identities and into other, quote, minority identities, particularly around race. The thing that's really interesting to me is the current research that's going on in minority stress, aside from what you all may be, is common sense and be familiar with, which is about the mental health effects and the correlation between minority stress and mental health issues and mental health diagnoses in LGBT and intersectional populations, is the physiological effect of minority stress, particularly over a lifetime, and how that may account for some of the health disparities we see both in racial ethnic populations and in LGBT populations who have great access to care, who have great adherence, who go to their primary care providers, but still have significant health disparities. And it may be, in fact, physiological over a lifetime. And there's some really interesting research about that. And so I think that's another place that we really have to look and to make interventions and to understand more about the impact of that.
Anyone else on that?
Yeah, I just want to add something. There has been a lot of, people are looking very seriously at toxic stress in children, and yet, how that correlates with poverty and discrimination and so on. So it may start way before. If you have a child that's grown up in poverty, receiving public assistance, going to poor schools, and then that child, realizes they're gay, and they keep going. You keep adding toxic stress to the whole equation, and it could be incredibly detrimental to their health, both health and mental health.
And Jeff, since you started all of this focused on gay men with HIV, doesn't HIV then add just another layer of this minority stress onto an already gay man?
I certainly think it does, and I think one of the other pieces that's missing and that we don't talk about or do enough research on are what are the resilience factors, which we've had a really difficult time trying to quantify or measure. But the fact of the matter is there are people who have minority stress, who have a lot of minority stress, who are doing perfectly fine. And then there are people who have a little tiny bit of minority stress who are completely fucked up. And so I think we need to recognize that there are other factors that we've not yet figured out and tapped into that's really driving which direction people go. This started out in the syndemics literature, where there were lots of people who had these syndemic effects of depression, childhood sexual abuse, partner violence, and they were seroconverting, and they were engaging in sex risk. But there were more of them that had been subjected to all of those things who weren't. And so I think that unfortunately, we still come from a risk paradigm, and we still, look at health risk, and we don't spend enough time doing research or interviews or understanding health protective behaviors. And how is it that some individuals in the LGBT community who are affected by all this stress and by HIV are still really successful in doing well?
Very much agree with this, and it's very important for us to think about what the mechanisms are. How A connects to B connects to C. If we can better understand, those mechanisms by which minority stress is, embodied, and then comes to have its impacts on mental and physical health, then we can try to understand those mechanisms and design the strategies to interrupt their impact. And a focus on resilience factors is something that's very important. Is it social support? Is it qualities of people's social network or who they associate with? What's the role of family? Or for that matter, spirituality. So there's a variety of areas here that would be very helpful for us to think about when we're trying to blunt the impact of minority stress.
There's been a lot discussed today about being undetectable, about the treatment cascade, treatment as prevention, and so much so that I sometimes wonder, and at least I know that among other positive people, they've brought up to me the idea that they feel as if all of the responsibility is being on them, that they're being treated through treatment as prevention efforts, which now are getting the bulk of CDC funding, more so than just primary prevention. Don't get it. It's become really about, let's get you on treatment, let's get you. Now, I understand the strategy, I understand the efficacy of that. It also feels as if people living with HIV have become problems to be addressed. And what if, God forbid, they don't achieve viral suppression? What if they're not undetectable? How should we feel about them? How should they feel about themselves?
So, it is, so this is a challenge, we want to.
Or are we being just too sensitive? Because that's always a possibility.
So, this is a remarkable, moment that we're in, where we can tell people that, by, engaging in treatment and achieving sustained and durable viral suppression, they will not only, benefit, their own life, but also be able to contribute to HIV prevention. And I think that that's can be, very powerful, motivation for people. At the same time, we don't want to shame people. I think we need to recognize that there are extraordinary barriers for people to engage in a lifetime of ART treatment. And we have this idea in some ways that the goal is 90-90-90, that we have % diagnosed and on ART and virally suppressed. That makes it sound like it's just the same 90%. There's the good people and the bad people. And the fact is, it's not quite like that. If you look longitudinally, it's very compelling to see the data from Dimitri here. Longitudinally, it's about a third of HIV positive people who are in care do not maintain consistent viral suppression over 2 years. And that's not little blips of viral load, it's actually pretty substantial viral load. And so what we really see is longitudinally, it's not that there's the good and the bad people, it's that everybody has challenges. And how can we identify those longitudinally going forward and give people the right support at the right time to make sure that they can stay suppressed?
I just want to put a pitch in here for two quick things. One of the issues, we always look at something in terms of the disease and the people affected or infected. In Europe today, there's a trend to do just general patient experience registries and patient registries, where and big data mining, where we're looking at everybody's health history and looking at across the board instead of just picking out a particular group where we have a particular problem. And so I think that is something that if we were able to do more of in this country, we would be able to look at the impact across lots of different characteristics and factors and experiences that patients actually have in general, not just pick out one patient population over another. And we'd see trends emerging too across different kinds of characteristics and experiences. We'd also get some patient outcome data from the patient's point of view. The other thing I want to say is I want to put a quick pitch in because we didn't really talk about trans people today. And when you were talking, Dimitri, about treatment equals prevention, one of the things we've been saying now around sort of transgender-related care is that access to transition-related care for many trans people, which is a form of treatment, is HIV prevention for trans people. And we really, and there's policies now that have changed that are allowing us to do that, but we still know so little about patient outcomes. One of the things we're doing at Mount Sinai, which I'm really excited about, because now we have a large enough patient population, because we have a Center for Transgender Medicine and Surgery there, is we're starting a transgender patient registry so that we'll be able then to draw on that population and draw on their experiences and look at some of that data. But we need other data pools for that. So we need to make sure that, that there are policies that allow us to do that across the board and not just in one center or another.
Thanks,
Can I
Dimitri.
make one quick comment? So I think ditto. And then the other comment I wanted to make had to do with sort of what an HIV test result means. So I love getting in trouble by saying this in certain venues, like the CDC, which is not you, where one of the things that's difficult is that the history of HIV is that someone gets an HIV positive test result, and all of a sudden everyone starts crying and mourning it. And so bottom line is that we're trying to sort of shift the conversation in New York City, and I hope the country, to say that the only HIV test result that is bad is the one that's never been seen, the one they've never had. So really from our perspective, what's really important is that when someone is diagnosed with HIV, that moment is a moment of fabulous creation. It's a moment where you can say you can change the course of your health and the health of your loved ones. And if you're HIV negative, you can also change the course of your health and the health of your loved ones. So our whole strategy behind the conversation of really acknowledging, and what you're going to see in our next continuum of care that we're going to launch, that the person who is living with HIV, who is engaged in care and eventually could get to viral load suppression, is really, from the public health perspective, completely not different from the person at risk of HIV exposure who's on PrEP. They're indistinguishable. So why should they be treated differently? So the idea of sharing the responsibility, both living with HIV and being potentially someone at risk for exposure, and saying we are the same person, I think is going to be the strategy of removing that weight from people living with HIV to say it's all your problem. Mm-hmm. It's not a problem, it's a moment of great opportunity.
And that was actually going to be my follow-up point, that in fact the beauty of PrEP is the fact that we're all in this together. We all have a role to play. We all have an intervention that is suitable for us. I was looking at, have I spotted any hands in the audience for any of this? Yes, go ahead. Oh, I'm sorry, somebody's going to want to bring you a mic. Hold on, she's on her way. Well, they need it for the live stream. Oh.
Is it on? There we go. I'm Daniel Simcik, by the way. I'm a newer project coordinator within CHEST and founder and CEO of HIV League. And what I've been seeing throughout this entire symposium is seeing people from different institutions, research institutions, and people working within implementation, people working within policy. Like these discussions have even kind of turned into semi-brainstorming sessions about new ideas and like how we can go forward. So, seeing up here people within those different institutions and who have been within that line of work for so long, what are the challenges that you have seen working, like implementation, working with research, and like what are the challenges that you have seen and how we can solve those challenges and like make the communication better to where we can get to the 90-90-90 and like solve, like get to those goals that we put in place. Because you guys are the leaders within these institutions, and yeah, it would be great to hear that from you.
Thanks.
You're not going to like what I have to say, but I'm going to say it. One of the biggest, one big challenge that we're up against is how difficult it is to get funded to do research. The system that, and forgive me, folks, and you know, Dr. Parsons has been a master of doing that, but it's still very, very hard to get money. I think one of the innovations that we've seen recently is PCORI, the Patient Centered Outcomes Research Institute, which is really, you know, and they don't have as much money as NIH does, but they've really changed the landscape and made research grants available to lots of different groups. And the mandate there is you can't apply for a PCORI grant unless you can prove that you have patients as part of the leadership team from the get-go. Not like afterwards as an advisory group, but from the get-go, from the inception of planning, you know, what the research is going to be on and why it's important. And I think, you know, that's part of the problem, that NIH is just so ingrained and it's so hard to get a grant. And so younger researchers, community-based partners, they just don't have access to the resources to do the kind of research that really would be more innovative.
Understood. It can be brutal, and it's the absolute least favorite part of my job, telling people that they did not get the grant. You know, but in terms of your question, you know, I don't know that there's any kind of, you know, magic fix, but you know, I would return to, you know, one of my last points there about, you know, the importance of working across disciplines and with multidisciplinary teams. You know, there really is a lot of value to bringing together a constellation of people who can view a problem from different angles and contribute different, you know, pieces to that wider puzzle. And you know, we heard a little bit earlier from Jim Tessororio about the value of doing that up front. You know, not at the end. You know, especially if you want to have policy impact. You know, not to say, oh, here I did this project, and what do you think? But instead to involve, you know, the decision makers at the very beginning. And we've tried to do that some more at NIMH. You know, some of these opportunities, like our Prep Implementation Science initiative, where, you know, that required partnerships between departments of health and academic researchers. And you know, that kind of model just tends to be much more fruitful in terms of doing work that ultimately can have real impact and lead to models, you know, that lead to uptake and real world programs. So multidisciplinary collaboration is one way.
And I think having these kind of dialogues, I mean, the fact of the matter is we all don't end up in the same room to have these conversations unless we organize a symposium like this. We all work in our own little silos. We all sort of have our own areas of focus. We all genuinely like each other, and we get so much out of these discussions, I think. But the biggest challenge, I think, is life. And we just don't necessarily have the time to come together like this to share ideas, to figure out how can we better inform each other. And so I think we just have to try a little harder to do things like this more often.
Can we commit to have this once a year now that you're 20?
Oh, well, sure. I'm not getting any younger, so yeah.
Any other
I mean,
questions?
I do think that really taking the opportunity to focus on the research to practice continuum and the emphasis on it, and, you know, doing it at a place like Roosevelt House that is, you know, the sort of epitome of policy. I think that it's exciting, and I would hope that this is the first of many of these.
Anyone else? Any final thoughts for the good of the order? I just want to say I have really learned a lot today, and I am very thankful for the invitation and for being here and kind of walking you through this. It's been great. I hope you'll visit me at myfabulousdisease.com or on Twitter at myfabdisease and get to know a Paz guy. And thank you so much for the panel. I'm going to turn it back over to the birthday boy, the anniversary man, the man of the hour. Once more, please welcome back and thank Dr. Jeffrey Parsons.
Thank you. This has just been a fantastic day. I can't even say how pleased I've been with the talks, with the questions, with the discussion, with getting the different viewpoints in the same room. I just think that I'm sorry we waited 20 years for this. So now we've had a good excuse, and I like the idea of this becoming an annual type of event. I want to again extend thanks to everybody who made this possible, the folks at Roosevelt House, Elizabeth and the Policy Center, the Provost Office, the President, everybody here at Hunter College who could not be more supportive of the work that we've done for the past 20 years. It is a treat to be in an institution where even when the right wing gets a hold of something about penis size, we know that our administration has our back. So I did want to say one thing. We are, the issue of transgender and HIV issues has come up a few times. We have just finished enrollment of a large study of trans women focused on HIV prevention. We are finally ready to analyze that data and start to present some of those results. We weren't able to do it in time for this, but we are having a community advisory board presentation at CHEST on October the 6th from 3 to 5, focusing on some of these results. And if you would like more information, you can email me, you can email Demetria Kane, raise your hand there, who's coordinating that, and we'd love to hear from people. We'd also be very interested in hearing if there are folks in the room who might be interested in joining our community advisory board to provide ongoing input to the work that we do at CHEST so that our next 20 years is even better. So thank you all very much.